Hey, welcome everyone to our March webinar for the All of Us Oneida campaign. Our topic today is understanding how cultural differences affect treatment in rural communities. My name is Jody McIntosh, and I am one of the directors of community engagement on the National Stigma Initiative at Shatterproof. We're so excited to have had the opportunity to bring this campaign to you with the support of funding through the Oneida County Health Department. Next slide. So before we get started, just going through some housekeeping so you can understand how to navigate the webinar. If this is your first time doing a Zoom webinar, we are recording so that this can be made available on the All of Us Oneida Facebook page for those folks who aren't able to join us live. You are muted and cameras off because this is a webinar format, so it's not a normal Zoom meeting. If you have any questions, we really encourage you to use that Q&A button. So everyone should have a button down at the bottom that says Q&A. Mine is in between the participants and the chat buttons. And when you go in there, you can literally just type your question in, and all of the panelists will get that question. They'll either be able to answer it within that Q&A box, or they may choose to answer it live on the webinar, but that will be indicated in the Q&A panel. And of course, you can use the chat. We love to hear from you. If you're agreeing with something the speaker is saying, if you're really feeling it, feel free to use reactions. We want this to be interactive as we go along. You can also adjust your view to be able to see all the speakers and panelists. So you would just click that view button in the top right corner of your screen, and then you would select either the speaker view, so that will only show you the person who's speaking at the moment, or the gallery view, and that will show you everyone. You can also select like a side-by-side view, so then you're seeing the screen as well as the speakers on the side. Okay, next slide. So our agenda today, we've already done our welcome and housekeeping. We'll talk a little bit about the All of Us Oneida campaign, and then we are going to jump right in and hear from our wonderful speakers today. We'll leave some time for Q&A, and we'll do our closing. So All of Us Oneida is an evidence-based public health intervention aimed to reduce addiction-related stigma. The campaign is facilitated by Shatterproof, a national nonprofit committed to ending the addiction crisis in the United States through a partnership with the Oneida County Health Department. So this particular intervention has three main objectives. One, we'd love to increase knowledge about opioid use disorder, and that recovery is not only possible, but probable with proper support. Secondly, we want to improve attitudes towards those living with and or recovering from OUD. And you'll hear our panelists kind of talk about stigma and ways we can kind of combat that a little later on. And last, we want to develop an understanding of the disease so people can better support loved ones with OUD. So we use an evidence-based approach, and there's really three parts. So one is this community connection piece, so connecting with community organizations across the county, and we've done that a couple different ways through needs assessments, and then having this webinar today, connecting with one of our community partners at Helio, and then also inviting all of you all to be here with us to share in this information. I would say kind of the centerpiece of our interventions is the story sharing. So we're collecting stories of people who have been impacted by addiction. So that could be people in recovery, their friends and family members, as well as providers of recovery or treatment services. And then in the case of Oneida, we've been really fortunate to have folks who kind of overlap in all of these categories. And the reason why we collect these stories is because we believe in what we call a contact-based strategy. So we want to make a connection for people who might not be impacted by OUD or might not know that they're impacted by OUD to connect with folks who are. And so seeing them in a very humanizing way. And then education. So we want to leverage our community-based organization networks to spread anti-stigma messaging within those networks. And then we also use our digital team to target messages to priority stakeholders. So as I mentioned before, this is a partnership with the Oneida County Health Department to implement a county-wide movement to end the stigma associated with substance use disorder. We're using that contact-based strategy as well as the collective impact model, which pretty much means we want to make sure that multiple stakeholders from different sectors are involved in this work. And we do this through our social media platforms and webinars to provide educational resources and share the stories of individuals affected by SUD. And throughout the webinar, we'll go in and we'll drop the links to our social media platforms if you aren't following us, so that you're able to see this information. And as I mentioned before, together we are humanizing the disease of addiction to end stigma. And with that, I'm going to pass it over to Taylor, who's going to talk to us a little bit more about today.
Thank you, Jody. So as Jody said, a part of this campaign was making connections within the community. So during our needs assessments, we were able to find a couple of themes that we found reoccurring that a lot of individuals who work within the substance use and substance use disorder field within Oneida County thought was really a huge topic to highlight. And one of those topics and themes that we found was centered around SUD and treatment as a discussion as it pertains to racial, ethnic, and cultural differences. So for today's webinar, we are focusing on the differences in addiction stigma treatment and recovery in various cultures and races throughout rural communities. We're going to take a deep dive into this webinar with Andrea LoParco and Heather Campbell as they share their expertise on the importance of understanding race and culture when addressing addiction. So Andrea, on to our wonderful speakers for today. Andrea LoParco, MBA, is a master's level professional with 15 years experience working in the nonprofit human services arena. In her current role as project director for Helio Health, Ms. LoParco collaborates with community-based organizations, schools, and court systems to coordinate mental health and substance use treatment referrals in both rural and urban communities. Heather Campbell is a master's level professional with 4 years of experience in the human service field. In her role as a counselor and team lead for Helio Health, she provides comprehensive outpatient mental health and substance use services that are person-centered, trauma-informed, and evidence-based to help meet the needs of clients that are served in both rural and urban communities. So I am going to go ahead and pass it over to our speakers.
Good afternoon, everybody. Thank you for joining us today. I am Andrea LoParco. I have been with Helio Health for just over 5 years now, working with adults with justice system involvement primarily. I also do quite a bit of harm reduction education for organizations and individuals throughout Oneida County.
Good afternoon, everybody. My name is Heather. I am an LMSW, and I've been working with Helio Health for about 3 years now. I was initially started in my role as a counselor and since have been transitioned to a team lead. So I work with individuals, adults, and children surrounding both substance use and mental health services.
Today's learning objectives. We're going to analyze specific differences and viewpoints of substance use disorder and treatment based on race, ethnicity, and culture in rural settings. Discuss forms of addiction stigma across various racial and cultural backgrounds. Examine the importance of how advocacy for culturally responsive care practices can increase trust and empower organizations, staff, and community. Next slide. First, we're going to talk about some of the cultural differences that we see in rural regions. Number one is distrust. Distrust of outsiders, of the community is very, very common. Rural areas tend to be very, very close-knit. And although families within a community may know each other well, it can also pose challenges with treatment. Sometimes people worry that because they live within the same small community, that their confidentiality may be breached, or they may be disclosing past trauma to someone that they have to sit next to in church, for example, and what will that person think of them? Health literacy is typically lower in rural regions overall. Outreach and education really is key to making sure that individuals are making the best decisions for their personal health. The more we can educate folks, the better off they're going to be able to make the decisions that are best for them in their particular situation, and taking culture into account when doing so as well. Transportation obstacles can make things very, very difficult in rural areas, specifically because of the topography and how spread out things are compared to what we see in metropolitan areas. Things tend to be much less walkable in rural areas. And because of that, that can pose a challenge. There can be, it's important to have access to a diverse array of services being offered, and we don't always see that in the rural areas. You want to think about, is the program offered considerate of the needs of the entire community? Are there programs to treat co-occurring disorders? Are we offering specialty programming, things like men's groups, women's groups, LGBTQ engagement? Those are all things to think about. They don't tend to be plentiful in that region, and they are super beneficial in engaging people that might otherwise feel kind of left out. There's fewer individual resources generally, and educational attainment and literacy is generally lower in rural regions, and even lower for minority populations residing in the rural regions. So offering things like connection to GED classes, connecting with the local schools, continuing education, trade schools, and colleges to help promote increased education and literacy is going to better off the community as a whole. Next slide, please. Next, we're going to take a look at what the rural social determinants of health look like. And they are a bit different than what we see in the typical social determinants of health based on the region. We look at things like community infrastructure, housing, transportation, environment, food, education, income disparities, race and ethnicity. And as we go through this presentation, you're going to see how each of these things play a part and how we can help mitigate the issues that come with them in rural areas to be able to help people the best we can. Next slide, please. Engagement in rural areas. So when you're trying to maybe start providing services in a rural area or expand services in rural area, your marketing plan to do so might look different. You really want to start with trust building. That is A1 when it comes to being able to work within these rural areas. Utilizing a boots to the ground effort is really, really important. So doing things like going out and finding what local events might be happening and offering to participate in those local events. So maybe it's something through the school, maybe there is a community celebration happening. Any way that you can kind of immerse yourself within that community, the more people see you, the more comfortable they will become with approaching you and asking questions. And you know, over time, they may take that may be the effort that they need to take that next step to be able to ask for more information on treatment or starting treatment themselves or asking questions for a loved one. Being able to put a face with a name and relate it back to an organization really is key. You want to research the demographics of the particular rural area you're taking a look at so that you can provide offerings that are inclusive of the community as a whole. And by familiarizing ourselves with the rural social determinants of health, we can find ways to create connections within the community while simultaneously reducing barriers and building trust within the community. Positive impacts can be made by taking a look at those social determinants of health and then utilizing them to assess and address the community's needs. So maybe you're doing a food drive, doing a giveaway of some sort that can be useful, initiating things like community cleanups. All of these things kind of help to build trust within the community and gain that trust as well. You want to take time to really meet the community members, listen to their stories, and pick up on what their needs are in particular. Next slide, please. Here's just some examples. We have a photo here of the Camden Holiday Stroll that happens every single year that we like to be a part of. They have, we've marched in homecoming parades. We've been at every tabling event we possibly can. Just an example of what engagement we have done in rural areas. Next slide, please. Diversity in rural communities. We first want to strive for health equity in every community, right? So health equity exists when all people, regardless of their race, sex, orientation, disability, socioeconomic status, are given opportunity and resources to achieve their highest potential for health overall. And if we look at the population of racial and ethnic minorities in rural areas, we notice that there seems to be a trend where they tend to be the youngest portion of the population versus non-Hispanic whites. Income in these regions tends to be less, and education tends to be less. So if we incorporate services that are specific to racial and ethnic minorities, it increases the level of comfortability and the likelihood that these individuals will engage. Also, because of the situation where the population tends to be younger, considering programming for younger populations, like child and adolescent services and things like prevention programming within the schools, for example, are a huge benefit. Across the country, many minority populations in rural areas experience significantly higher poverty rates. This disparity is even more pronounced in the rural areas where poverty rates are as high as 30.7% for African Americans. In rural areas, 55.3% of Black workers make less than $15 per hour compared to 36.9% of white workers, and 60.3% of Latino workers make less than $15 per hour in rural areas. Next slide, please.
So from a clinical standpoint, there are also many challenges among these rural communities. Rural areas are less likely to have multiple providers for people to choose from. So unless an individual in need of these services has transportation, then they don't typically have many options for what they would like their treatment to be like. We could be doing things, like offering telehealth services or having satellite services could be one way to provide more options to individuals in these communities. Getting buy-in from racial and ethnic minorities can take a little bit longer in rural communities because of things like stigma and trust. So it's important as clinicians that we keep this in mind and we practice patience and we practice meeting people where they're at. Another concern when we talk about small areas is loss of anonymity. So expressing past or present trauma or hardships to somebody that you're likely to see in the grocery store or that you're likely to run into in the community can cause a lot of apprehension for people. So as clinicians, we can do our best to mitigate some of this uncomfortability by having these conversations surrounding confidentiality and surrounding the laws that protect them. Psychoeducation is also something in these settings that's really important because, like I said, behavioral health still carries such a stigma in both rural and BIPOC communities. So the more that we're able to talk about the uncomfortable, the more that it becomes normalized and the more that it will lead to other people being able and willing to join our conversations. We need to be able to help people understand that the old mentality of sweeping things under the rug is out and ending generational trauma is in. Access to auxiliary services in these areas are also lacking. So being able to have a plan of connection for services in outside communities is really helpful and can help decrease some of the anxiety that some of these people may have in these rural communities. Next slide, please. So our worldview is essentially the lens through which we view the world, and it's shaped by our cultural beliefs and values, and it can have a real impact on our behavioral health. So having negative or distorted views of the world can cause people to feel depressed or anxious or cause them to isolate themselves more. So being aware of our own assumptions and our own bias and values about other culture allows us to take an inventory of our own implicit bias. It's important for providers in these rural areas to have an understanding of how rural culture impacts things like socioeconomic status, education, healthcare literacy, and lack of specialty program for these BIPOC residents. Awareness is really key when it comes to being more culturally competent. So it's important that we're educating ourselves about cultural norms and stigmas that are related to behavioral health and being prepared to have a plan to help mitigate these concerns if these are things that clients do bring up. Next slide. So there are higher risks associated with rural areas. Suicide rates between 2013 and 2015 were 55% higher than urban communities. Black and Hispanic individuals are 20% more likely to report serious psychological distress than white people and are less likely to access or even complete treatment. There are also higher rates of depression and untreated mental health issues in rural communities, and BIPOC individuals in these communities have also self-reported poor physical health. The rates of alcohol and substance misuse, which are often co-occurring, so often paired with a mental health disorder, are also higher in these communities. 37.8% of individuals who are aged 12 to 20 years old struggle with substance misuse in these rural communities compared to small and large metro area peers being roughly 35.3 and 34.3%. Next slide. So there's also a lack of specialty programming, which Andrea touched on briefly in these rural areas. And having these specialty programs are typically things that are helpful for engagement within these minority populations. So having specialty programming, it offers a space where individuals are more likely to have similar experiences and more likely to feel comfortable engaging in these services. Substance use admissions of individuals reporting two or more races look different than admissions for non-Latino whites and are also more likely to be referred for these services by the criminal justice systems. So being able to establish healthy relationships with criminal courts and family courts and any other specialty treatment courts is really important because referrals from these courts are happening more often. Being able to educate courts on organizations with quick access to care is really key. There also needs to be an understanding that treatment completion is not as high as it is for non-Hispanic whites, and things like stigma, access to services, health insurance, fear of losing housing are all things that contribute to this. So we have to be prepared to discuss these barriers to treatment access and being able to offer ways to help alleviate some of these concerns. Next slide. So now we're going to be looking at the barriers to BIPOC treatment. So there's an overwhelming lack of access to services in these areas, and institutional discrimination and systemic barriers limit access to mental health care for people of color. Things like racism and stigma create hurdles, which make it harder for individuals to seek and to receive these services. The absence of culturally informed treatment options also contributes to this problem. So mental health services also often fail to consider diverse cultural backgrounds, which can lead to inadequate care. There's also a lack of workforce diversity within these fields, with 87% of treatment providers being white. Having more mental health professionals who understand the experience of people of color is crucial. As we know, there are many negative stereotypes and discriminatory attitudes that play a role in how these issues are perceived within the communities, and this can be discouraging individuals from seeking help. Keeping in mind too, the way that COVID-19 had an impact on these individuals. COVID-19 had an impact on marginalized groups, and stress associated to being part of marginalized groups intensified during the pandemic due to issues surrounding things like unemployment or loss or just overall disrupted social lives. And those things had a big impact on mental well-being. Next slide.
Now we're going to talk about 3 different kinds of stigma: public, systemic, and self. Public stigma, also known as social stigma, these are negative attitudes or beliefs held by society or the general public about a particular person or a group of people. These negative perceptions can lead to social disapproval, discriminatory behavior, and when it comes to behavioral health, public stigma often manifests associations between mental health or SUD and danger. So maybe it's the idea that someone with a mental health issue is also dangerous just because the mental health issue occurs. Some examples would be using slang or labels to exclude people or groups, assuming someone with mental illness is dangerous, as we just talked about, believing that people with physical health conditions are unable to contribute to society, right? These are all stigma, public types of stigma. We have systemic stigma, and that impacts policies, regulations, and decision-making processes. And unlike individual level stigma, which affects specific people or smaller groups, systemic stigma has a broader implication for the entire population. This is what leads to things like healthcare inequities, employment issues, educational and social services. Self-stigma, and that refers to negative beliefs an individual holds about themselves. When someone experiences self-stigma, they internalize social and societal stereotypes with prejudice. Examples of this include like feeling alienated, believing stereotypes about their own group, history of experiencing things like discrimination. Next slide, please. So we look at stigma, could be stigma related to people's cultural beliefs. Oftentimes, people will consider seeking treatment as a personal weakness, for example. And we've heard this from our clients before. Their family doesn't understand what they mean when they say they're struggling with their mental health or they want to see treatment. They tell them to man up, everything will be okay, you know, tough it out. It can lead to shame, silence, and avoidance. And you'll see here that the silence is in bold. Silence is the worst thing that you can have occur when it comes to someone's overall behavioral health. You need people to talk about it. You need people to connect with others that have been through it, connect with others that can help them through it. Provider bias and inequality of care, a history of dealing with racism, discrimination, and trauma really changes the way someone accesses treatment and what their overall opinion is on seeking treatment in the first place. Lack of specialized care, cultural humility training for practitioners, that is very important. Making sure that the practitioners are utilizing cultural humility and education in that area to make sure that everyone that is being offered treatment is doing so based on their ability to look at their cultural belief system, for example, as something that can impact what their overall treatment looks like. So it's time to switch the narrative. We need to talk about it. And you're going to hear us say that over and over and over again. The more we can talk about it, the more we help reduce the stigma. Next slide, please. Some approaches to reducing stigma. Talk about it. Talk. The more people hear other people talking about it, the more comfortable they will be sharing their story or seeking treatment. Education, things like cultural humility training, harm reduction training, person-centered care. The more we are able to educate and improve people's health literacy in all of the demographics that we serve, the better off people are going to be and the more likely they will be to seek care and continue with treatment. Consider language barriers. So implement things like translation services or translating forms that may be necessary in languages that are individuals' first language. Incorporate peer networks, and this was a big one. There's something to be said for being able to connect to people who have had a similar path and for one of them to be able to say that they have come out on the other side of it. I think it's incredibly rewarding, the peer work that is done, but it also gives people a certain level of comfortability to know that they're dealing with someone that has been in their shoes. Practicing cultural humility, it improves communication and renders a more accurate diagnosis overall. Recruiting diverse providers in rural areas, like Heather touched upon. Individuals have said time and time again that oftentimes, at least in making the initial connection with treatment, they're more comfortable doing so with someone who looks like them. So having a diverse population of providers available to connect people to is important as well. Being aware of long-lasting impacts of things like historical trauma, they exist. People go through them. We want to put people in situations where they're not being re-traumatized. That's super important as well. Next slide, please. We're going to look at a clip right now from seizetheawkward.com. I absolutely love this campaign that is going on right now. It is utilizing people of color to create, they've created a website and commercials about talking about things like substance use and mental health issues and trying to get the conversation started. And they're using familiar faces to younger individuals to kind of get their attention. I think it's off to a really great start. The website is phenomenal. And now we'll take a look at this piece.
I've always been told I gotta be strong, thick-skinned, stiff upper lip, tough as nails. But to be everything for everybody, it wears on you. Black don't crack, they say. But it can. I can. We all can. Y'all, it's okay to not be okay. Reach out to a friend if you see them going through it. No matter who you are, being vulnerable is what makes us whole. Learn how to help at seizetheawkward.org.
So again, this campaign is really doing a great job at opening these conversations up to younger people and people of color in particular to try and help reduce the stigma and let people know they're not alone. It's a huge factor. So thank you so much.
Thank you so much, Heather and Andrea, for your presentation. And now we're going to move into our Q&A portion of our webinar. So please feel free to drop any pending questions that you have for our speakers, either in the Q&A chat or the webinar chat. We do have one question, and that is, where does autism fit within your treatment plan?
Well, it was, where does autism fit within our treatment plan?
Mm-hmm.
So
And I
we,
think,
go ahead.
no, go ahead.
So we, if you're talking about Helio Health specifically, we are able to, we work with individuals, on who have autism spectrum disorder. I think, it's really important to be able to try to take a collaborative approach with treatment planning and making sure that, whoever you're treatment planning with is involved in the treatment planning, and, it's their treatment, right? At the end of the day, that's something that we have to keep in mind, is that this is their treatment. We have to be the ones to kind of help guide them, but not exclude them from deciding what it is that they want to work on, or deciding how it is that they want their treatment to look like.
Thank you, Heather. So we do have, as we wait for additional questions in the chat, we do have a question to pose to our speakers. How have either of you seen cultural responsiveness show up in areas outside of a rural community?
Heather, did you want to speak on that, or do you want me to take that?
It's up to you.
So, culture outside of a rural community, I can give you an example. Again, I do a lot of work with harm reduction in our area. Until just a little while back, probably over a year ago now, I did not have a lot of requests for Narcan or Narcan training coming from the Black or brown communities. Until there was an event where a young man used cocaine, which was laced with fentanyl, and he lost his life. And all of a sudden, people had a concern that they didn't typically have before. It was kind of the start of us seeing people that were not actively using opiates, for example, that were losing their lives, or know someone who had lost their life due to a fentanyl overdose unintentionally. In response to that, I had put up a post on my own personal Facebook page, like, hey, I have access to Narcan. I can bring you a kit. You can inbox me, so it's confidential. Don't worry about it. And I think the individual sadly lost his life on a Thursday. I think between Friday and Sunday, I had met with 36 people and dropped off 36 Narcan kits to individuals who never once considered that they were someone that needed to have Narcan. It really opened up the community's eyes at that moment in time. So we were able to jump right in and make sure that people got the education, got the Narcan, so that was available within the community. It also opened up many conversations about treatment. A lot of people said, what does it look like to come into treatment? What does that process look like? I have a loved one that I think needs treatment. How do I know? How can I help them? So it opened up the space to have a lot of really good conversations as well. So that's just one example of how we were able to jump in and be culturally, responsive in that.
Thank you, Andrea. Another question, how can we practice and develop methods of cultural humility in our day-to-day work?
So I think in our day-to-day work, we can be doing things like Andrea touched on this a little bit, but providing translation services. At Helio Health, we use a 24/7 access to this translating service, and it's pretty much has any language that you could really need. So things like that, or even offering materials to clients in their first language. So, if you have like a handbook that gets handed out as part of an admission process, making sure that we can have materials for people to read that's in their first language. Developing treatment plans that can accommodate a person's cultural or religious beliefs is also a good way to practice cultural humility in our work. And of course, having ongoing trainings for cultural humility and, trainings beyond just like a clinician or a direct care worker, but, cultural humility trainings for anybody that's within an agency.
So we have a comment. We have a question from Saskia. She says, I think one of the elements we often see in rural communities is there are deeply rooted cultural traditions and beliefs. How do we bring new information and ideas to these communities with consideration for how to be respectful of these traditions?
I think the first step is to educate ourselves on what those traditions look like, right? So, the best way, we want to be respectful of what their traditions are. We don't want to overstep. Doing that will actually take you backwards in trying to connect with these individuals. So I think we spoke earlier about knowing the community and taking a look at the demographics and the overall culture of the community. Speak to people in the community. The elders are a great source of knowledge in these areas. It's one of those situations where everybody knows everybody. You sit down and have coffee at the local coffee shop with a couple of the elders and see what information they can provide you with about the culture of their community. And by doing that, then you're able to, take a look at what your offerings are and make sure that you're not overstepping or that you're communicating in such a way that you are very respectful of their culture and their traditions in general. It's really all in the approach, and it's all about education. So it's educating yourself about the community you're working with, and it's educating the individuals that you're working with about what is available to them and how you can help. Great question. Thank you.
Great question. An additional question, what has been the biggest challenge you've encountered in your work when delivering services in rural areas, and how have you overcome those said challenges?
I think there's, we talked about a lot of different sort of challenges in working in these rural communities, but I think the biggest one is, getting that buy-in from somebody and being able to build that trust with somebody. And I think really at the end of the day, the biggest thing is being consistent with people and, being able to really listen to them. It's like Andrea kind of touched on, it's really important that when we're going into these communities that we are understanding the communities and we're understanding the culture that surrounds these communities, and we're not seen as somebody who's coming in and wants to take over or change things in a certain sort of way. So I really think having open and honest communication with people, and I think that's been really helpful, is just being patient and being consistent with people.
Patience a big one. I mean, for example, when we first started working, doing our work in Camden, New York, we very quickly found out that it was going to take some time for the people that needed us the most to connect with us. So the initial approach was to use peer services and harm reduction efforts to keep people safe until we could get folks ready to make that next step to go into substance use treatment. So, being creative, being patient, and seeing, you know, what you can offer that people can digest in small amounts as you go and develop that relationship has really been beneficial.
Absolutely. Thank you. Great question. We have another question. This makes me think about how we can identify our shared goals and values between our work and the community. Do you have ideas about what those goals and values could be in those conversations?
You know, shared goals and values, I think working together is always going to kind of give more of an impact than if we're all trying to, you know, work in our little silos. So having the biggest impact on the communities is really taking the information that we've gathered individually and kind of coming together to make a bigger picture and create a more inclusive plan to make sure that no one is being left out and every service that's being offered is being offered. The lack of services can be one of the biggest detriments in rural areas. So filling that gap where we can, but I think here in Oneida County, we do a really good job at working together to make sure that everybody is getting what they need. And I see that kind of repeating itself in other regions as well.
Thank you. And speaking of connecting and collaborating together, are there resources available for providers in rural communities to connect with one another?
To connect with one another within the community. I mean, you can always reach out to Helio Health using our website, www.helio.health. You know, we are available on social media. We are on Facebook, LinkedIn, Snapchat, and I think it's what is the new Twitter?
X.
Okay. So you can reach out to us that way. You're always welcome to send us an email. I will put my email address in the chat and Heather can do the same. Well, I'll add Heather's as well. You can always reach out to us that way. We're always, you know, able to help each other, right? So feel free to reach out, connect if you need any type of information that we can help you with service-wise. If you need harm reduction education or anything of that nature, please feel free to reach out to us.
Absolutely. And just a question just for anyone to put, anyone in the chat, just a question for everyone. Just put in the chat below, how have you seen stigma show up in your day-to-day work? Would love to have everyone kind of chat and talk back and forth with each other as we as you all think about that.
I can tell you just from our we see stigma kind of stop people or delay people from entering treatment on a regular basis for fear of being ostracized or misunderstood. You know, that happens commonly. I know one individual in particular that we worked with where stigma stopped him from continuing in his recovery. So his family members were very much against medication-assisted treatment. He was stable on Suboxone, doing very, very well in treatment, had gotten a considerable amount of sobriety time under his belt, and his family really pressured him, feeling like it was giving up one drug for another, and encouraged him to kind of titrate down off his Suboxone. And he did, and he relapsed. And we saw this cycle happen over and over again. He would get back on it, he would stabilize, he would do very, very well. He would have the family members and his girlfriend who really pressured him to once again come off of it, and he would relapse. And it happened over and over. It was even a situation where we brought his family in with his permission and gave them some education about the benefits of medication-assisted treatment and how it really played a role in his sobriety and his stability. But the stigma that came along with it was just too much for them to bear. And so he was putting himself in these situations that really made him jeopardize his recovery. and could have taken his life. I mean, thankfully, it wasn't a situation where he ended up overdosing, but you know, that stigma really had an impact on him.
Yeah, I think stigma is something that we see, you know, in our day-to-day work, whether it be, you know, somebody who is really apprehensive about, you know, starting a program or starting services because of the stigma that follows. You know, there's a lot of fear of being ostracized or misunderstood. And, you know, I really think that as you can see, a common theme that we've been talking about is conversation, you know, really being able to have these uncomfortable conversations and being able to, you know, normalize mental health and normalize substance use. And at the end of the day, those are things that don't discriminate. So having these conversations, I think, is, you know, one step in the right direction of being able to reduce or end the stigma.
Yeah, a couple of comments in the chat. Stigma and biases are showing up more and more in terms of generational diversity and DEI trainings. One of the big ways I've seen stigma show up in rural areas is that people view addiction as a choice. We also have a comment. I've seen some nurses worry about drug-seeking behavior, and some will not ask the patient for their pain levels. They wait until the patient tells them that they are in pain because they really do not want to give out pain medications like fentanyl and morphine. But some patients may not feel comfortable advocating for themselves and speaking up about the care that they receive, and may not say anything when they are really in quite a lot of pain. Wow. Huge.
I think I've definitely seen in rural areas in particular, the attitude that addiction is in fact a choice and not a disease or a health related issue. And that take on it can be, you know, very difficult for people because they don't, when someone views it that way, they're less open-minded to understand the different recovery options that are available or be tolerant of the recovery options that are available. Things like MAT and things of that nature, they tend to be against them as well. That idea really is stigmatizing for sure. Strong values around autonomy, absolutely. Absolutely. And the smaller the region, the less you have, right? I mean, I know, you know, just in talking with Heather and some of the folks that she's worked with, that it's a big fear. I'm going to come to you and I'm going to disclose all of this trauma and all of these things that have occurred in my past. And then you're going to see the person that caused my trauma in the grocery store on Saturday. And then you're going to see me on Monday and, you know, worried what opinions people will have, even opinions the provider might have of, you know, other individuals that might be intertwined within that person's story. Individuals can want to protect people too. So it gets interesting for sure. And you just want to make them feel as safe as possible. If they don't feel safe, they're not going to fully disclose. And if they don't fully disclose, they're not going to get treated to the best degree that they can be.
This is such a great conversation. And we want to make sure that we continue to have these conversations as a community. So for us, feel free to follow us on our social media platforms. We're on Instagram, Facebook, and YouTube as All of Us Oneida. I also put Andrea and Heather's information in the chat. So please, let's keep these conversations going. Let's continue to collab. We are all working towards the same purpose. So definitely want to keep those conversations going. So please feel free to, if you want to connect with each other, and let's keep conversations like this going. Huge shout out to our speakers, Andrea and Heather today. We want to thank you so much for putting together this presentation. And I also want to give a huge shout out to everyone that has attended today's webinar. We really appreciate each and every one of you and appreciate all that you do for your communities.